Thank you, Anirudh, and thank you, Ritesh, sir, for making me part of this IC. So my topic is fairly common. Most of us would be dealing with diabetic vitrectomies, and my topic is to manage or common errors. So I would show what errors it makes and what it makes to avoid those errors. So like in this case, as what we can see, that when we make a board, sometimes we see that there are bleeds in the anterior chamber. So my questions to the panelists would be how to avoid this, or how to not have this kind of bleeds, and what would be the cause for this bleed.
You mean bleed in intravitreal?
Bleed in the anterior chamber, yeah. So like when I'm making a port, as you can see, there is a bleed in the anterior chamber, and then I have to take the port out and then again try to do. So what can be the reason in this case?
No, there is obviously either from the sclerotomy side there is some proliferation already anterior hyaloid, that can be one reason, and these are difficult to anticipate unless you have, if there is vitreous hemorrhage, you can't see the fundus, you can't make out, and these are, as the situation evolves, we'll have to handle that. But if it's sometimes resurgeries where we have there, we are aware of this situation. Apart from the anticoagulant, patients may be on those antiplatelets, and apart from that, if there are areas where you can see actually that this area is quite anterior traction is there, you avoid those areas. That can be made out if you can see the periphery.
So in this also in resurgeries, not for you, for the youngsters, avoid the site of the previous port. Just go away from it, because that is the site which is going to have a problem.
Yeah. So in this case, what I thought was I was very anterior, and I had gone through the ciliary body, and whatever the heme was there was actually occurring in the pars plicator, and that was coming from the root of the iris into the anterior chamber. That's what my thought process. Yeah, but the other points are also very correct if the case is.
Divyansh, one small point. Unpicked up or silent NVAs, the sudden decompression.
Yes, sudden decompression. Yeah.
Hyphema into the anterior chamber.
Yeah, so that also you can make out. In this case, it was coming from behind, kind of thing.
Yes.
And there it will come
from over the iris and then going behind. Yeah. So what would be the take of panelists on cases like this, where you have done a phaco and luckily the surgeon has done a superior temporal, and if it's a temporal phaco, how would you want to make ports in this case? Because port is the first and foremost important thing in cases of diabetic vitrectomy, where if the alignment is not correct, your achievement of vitrectomy in superior-nasal, superior-temporal may not be as good. So what would be the take on the panelist first?
Suture, even the side ports.
Even the side ports, that's true.
That really helps. And most of these are small gauge. So instead of making a bevel, just go straight, direct entry with 27G. And once you have one infusion in place, the other ports you can make by raising the infusion pressure.
So any preferences of the surgeon doing a superior versus superior, temporal versus temporal, any preferences?
Yeah, for me, astigmatism is not an issue in diabetic vitrectomy. If I get to CF 2 meters or 6x60, but I do my own phacos, it's always superior, and I don't have any issue. And obviously, suturing the main port is always recommended if there is any doubt. But overall, I would prefer a superior.
That's true.
I do vitrectomies with 2 cataract surgeons, and one cataract surgeon prefers that I actually make the ports before I start the cataract surgery.
Okay.
And I don't switch on the infusion. I connect everything and then he does the cataract surgery.
Mm-hmm. I'm not sure our cataract surgeons would be comfortable, because they want to finish their case and then go away and then with whatever is there.
If you do a pre-fixated infusion, in the sense the cataract surgeon doing a temporal incision may find it difficult again, with that blocking.
So this case assessment, if in my early, so what I'm presenting is because these are the errors which I've done in my early life and I've learned from it. So this was the case which I saw the OCT and I decided, okay, there is some traction temporal to the fovea. It is causing a TRD which is just encroaching onto the fovea, and there is a TRD which is involving the papillomacular bundle. And I needed to assess, because it was looking like, yes, the PVD has already occurred and it would be a very nice case for me because there is no PVD and the attachment is very gross. So whether I should just go on this, or whether my plan should be according to this to avoid further errors, or I should do something else also. So what would be the take of panelists on that?
In terms of how to go about
plan this.
Why do surgery?
So no, surgery has to be planned, but whether means in my case, because I want, if the PVD is there, it's a simple case for me. If the no PVD, because already there would be, as we can see, the PVD attachment is already at the edges of wherever the attachment of the vitreous is. So like this.
That's why I'm asking, what was the vision of this patient at this
I
point?
do not remember, but it is in between 612 to 6, not 66 and 69. So in. Why surgery?
So fovea is looking weird.
The fovea is lot of time. I know this can progress, and I don't deny that there probably may come a time when you will need to do a surgery. But if you see this patient for the first time, if I see this today, probably what I'll do is I'll just observe this patient, probably reassess them after a month or 2 months and see if the traction is progressing.
Traction is worsening,
if that is progressing, that's a time for you to do a surgery. If it stays stable, because there will be patients where it will stay like this for ages altogether. And then you don't need to intervene.
This is the hard way I had learned.
Because Divyansh, the first thing is indication for surgery when it is involving or threatening the fovea. In your case, fovea is not involved and not imminently threatened. So like Mudit said, we will just observe, wait. And many times they would just go on for years.
Having the same vision.
And surgery, all said and done, can cause problems.
While these are the contraindications or relative contraindications, there still can be an indication for surgery in this kind of situation because of a vitreopapillary traction, vision going on. You document that. And obviously if the patient has not been lasered earlier, and you have to do PRP and see if that stabilizes. But if still it is increasing and your vision is going down, it's an indication. But when you say PVD is there or hyaloid, there's no PVD in this. There's
just the posterior hyaloid separation.
Posterior hyaloid separation. That too, when you go and actually do these cases with triamcinolone, invariably there is vitreoschisis. There will be another membrane. I don't know if you are showing the video here, but invariably there will be a layer on top of the.
So as what the panelists are suggesting, these cases are not easy, and it has to be dealt with utmost caution. And yes, the OCT, which is giving you a pseudo appearance that the PVD is there, but actually it's an IPVD, and the PVD is already there, only on the posterior pole. And cases in which we are able to see the periphery very well, those are the cases which would be having more difficulty at the time of surgery. So this, fortunately and unfortunately, I took up for the surgery, and as we can see, the vitreous attachment is grossly on the posterior pole. So the discussion at this point was whether I have already jumped into the surgery, which we were discussing whether to do, not do. I was an aggressive surgeon before, and then after a lot of mistakes, I have learned that
you are growing up,
growing old. So
growing up
with a lot of gray matter and the gray hairs involving. So whether to go from outside in or inside out, I think we would not have operated for surgery. So we go to the full part of the surgery where I had done the surgery and then managed how well. So I could see there was some detachment on the nasal side. As you can see, the attachment is only in the peripapillary area, and anterior to it there is no PVD at all. So all that I am trying to truncate and then induce the PVD further. But in this cases, because at that point of time, again, I was an aggressive surgeon. Okay, I didn't thought of giving an anti-VEGF before the surgery, and as we can see, most of the time the surgical view is occluded by hemorrhages, when I thought, okay, I should just cauterize whatever is important. So as minimal as cautery and as better it can be. So what would be the take of panelists in this case, whether it is bleeding, when to cauterize and how to cauterize? Using how much cautery is enough and how much is more?
Minimal cautery, and then lower the pressure. Like if you are doing cautery at 30, which is normal for most of us, lower it to 15 or 10 and see if that point is oozing. If that is not oozing, there is no need to apply more cautery.
More cautery, that's true. Any more comments, sir?
Yeah, this kind of case where most of the fibrosis and contraction is over the disc. Usually what happens, we see a lot of arcade contraction, tabletop. There I think about inside out or outside in, but where there is vitreopapillary, mainly on the disc, just go there. Obviously you do the rest of the vitrectomy first, just the hyaloid is remaining. Disc is the best area in terms of, other people talk about bleeding, but as long as it's avascular, You just lift it from there gently, and the remaining
trim it around him.
highlight. So it just comes as a nice. In this particular, it can't be done in any other cases. This particular.
It does come, and generally you find a very nice plane between the disc and the temporal.
Yes.
There is always a hyaloid bit lifted there, which you can gently truncate and find the plane to disc.
And
I
the
totally
disc is the
agree.
best area where you avoid break, because you can't create a break over the disc.
That's true. So, Ritesh, do we have time?
So I absolutely agree with what RN and Dr. RN and Dr. Vishali are saying. Just assess our disc, and momentarily for that step, I just take the bottle height to like
Little high to
AIOP260,
control
pull
the-
it, just gently lift it and leave it, and then you can just. And I don't try to be too aggressive nasally. Once I have my macula and temporal done, nasal,
Just trim
I'm
it and
not
leave it, yeah.
too concerned about
Yeah.
it.
So, Dr. Ritesh, shall we continue? It's 10. So, okay, so this case, as what the continuation, what we can see as being an aggressive surgeon, I am seeing the patient again the second time in the OT of developing a detachment, and this is the PFCL which I have put and tried to identify if there is any
Not
SRF.
visible probably. It's not visible.
I think यहाँ उधर इधर दिख रहा है, but वहाँ नहीं दिख रहा है. Nothing can be switched off. Yeah. All.
That's how a
So
diabetic patient
this
will
was a
feel.
case where the same case continuation from the OCT. I did the fantastic surgery. Then the patient landed up into an RD, and then so the problem was I thought the retinal detachment has occurred because of the cautery which I have done. So that's why my question was that whether I had created a break of over enthusiastically cauterizing the bleeders, because what I could see that small area where I had cauterized before, that's the area where the detachment or the break was. And the posterior pole was only detached, the periphery was attached, and so the question is what could be the cause of break? Yes, obviously we couldn't see the video right now.
See, aggressive cautery, especially when you still need to tackle membranes around it. The cautery will make that retina
Contract
weak, and then you're doing a lot of dissection around it. The break will keep enlarging. So as Dr. Vishali was saying, avoid cautery or minimal cautery, especially in the areas where still membrane dissection needs to be done. So we can probably would have avoided it. I mean,
break and then laser it around. Yeah. So this was the learning which I got from this, that I
But
was
low laser. Sometimes laser itself can cause
breaks.
So that's
we're
a very important point. So
Very
we
true.
all say, okay, we do cautery laser around the cautery, but it's an elevated retina, there is hemorrhage, and you do the laser, you won't realize that you have created a. You think that it's whitening, but sometimes you see a smoke coming out,
Yeah.
or a pop.
Pop up.
Pop,
coming
yeah.
out. That means you have created a break, and if you don't tackle that, that means you have to keep on enlarging the area of laser. But if that is not assessed immediately and you don't take action on top, so if there is an elevation, don't try to laser on top of the elevation. If there is hemorrhage, that's why we say earlier focal lasers, don't do in the area of retinal hemorrhage, don't do laser, because the hemorrhage will absorb
the
laser energy and create a break.
That's true.
So one way to get around this is, instead of short duration, normally if you're using endo laser 120, 150 and duration of 100 milliseconds, instead of keep on increasing the power to getting, if you don't get the laser burns, increase the duration. Long duration laser is safer versus a high power short duration. Short duration high power will create a break. Long duration low power is just a small, it's like cooking on a slow flame. So that's what
You can
That's it.
use that instead of cautery also.
Yeah, that is also one.
that's what
yeah.
Steve saying
Charles
that
does
don't
that,
use
yeah.
cautery, I use laser, and we all end up saying I never get diathermal or
Laser induced, yeah.
laser induced. I can't, hemostasis is not achieved, but probably he's not able to say or what. I think it's long duration and low power is
Low
what
power.
you need.
Ritesh, shall I continue or because
we'll have to wrap up.
Sure.
Dr.